I'm going to talk about registry data. I'm going to draw from two registries that were built to address osteoporotic fractures. I want to thank Jens for his willingness to look at these. Come on, darling. I know you can work. Diverse ways of taking care of patients. I admire him for being open to that diversity, and that diversity not only in sponsoring point counterpoint for each of these topics, but also he expresses this same diversity in life itself and pursues diversity even to the point of fashion and music. He's willing to embrace the only two individuals who have actually trademarked their tongue. So Mick Jagger and the Rolling Stones with their red, lovable, look-alike lips logo, and Gene Simmons. And although I thought for the sake of brevity I wouldn't go any further into this, but you'll notice that he did not wear the mask, but I didn't put up any pictures of what he was wearing that night because some things should stay private. And if Shirley was going to let him go out looking like that, then it's okay. It's okay. But suffice it to say that Gene Simmons and Jens Chapman have the same tailor. So what I'm talking about is osteoporotic vertebral compression fractures, and the impact of this silver tsunami is independent of where you live in the world. The cost of it is enormous and growing. But it's also important to recognize that non-surgical management of this condition is lethal for the geriatric population. In two separate talks today, there were discussions around a 30 to 40% mortality associated with osteoporotic fractures. They happen to be up in the proximal cervical spine, but they are also in the hip. And essentially what you're seeing is the non-surgical management of this condition is expensive, and the mortality and morbidity are enormous. Whereas if you cement these fractures, you cut the morbidity and mortality in half. And these are 5 studies that looked into mortality rates associated with post-vertebral compression fracture. And that's 3 million fractures. A 6th study was done by Josh Hirsch and Doug Beal, and what it looked at was the impact of the 2 sham articles that were done in 2009 by Kalmas and Bookbinder. And what those articles purported to show was that vertebral compression fracture treatment was no different if you cemented the patient or if you did not cement the patient. And what Hirsch and Beal did is they looked at the frequency of cement augmentation before the articles and the frequency of cement augmentation after the articles. And what they found is cement augmentation plummeted. And consequently, 5,300 to 6,800 women had early death associated with non-surgical management, because if you're not cementing them, you're going to treat them with neglect. The other thing that they calculated was the number needed to treat before you saved a life. Now, for osteoporosis cement augmentation, that number is 15, and that is roughly equivalent to the NNT for renal dialysis, and it's much less than the NNT for acute cardiac heart attack treatment. The more you treat them, the greater the number of women's lives you save. Paul Anderson gave us an article where he dispelled one of the myths associated with cement augmentation. It was originally proposed that cement augmentation, if you did a T12 burst fracture, you would cause a T11 or an L1 fracture to subsequently occur. And what Paul's article showed in a large administrative claims database was that we are still failing to treat these patients. And in the 1/3 of patients that we did treat, the fragility fracture rate above and below actually went down. and the highest rate of secondary fracture, 1 out of 5 per year. 1 out of 5 patients with a vertebral compression fracture per year, if they are not treated, they will have a subsequent secondary fragility fracture. What Paul also showed is we are vastly neglecting these elderly women. 92% of them did not receive treatment for the fundamental cause of their fracture, which was osteoporosis. Paul also showed that if you did treat them with osteoporosis medications, you cut their secondary fracture in half. So what Paul's conclusions were that cement augmentation does not worsen secondary fragility fracture rate, that osteoporosis meds decrease secondary fragility fracture rate, and there's global neglect of osteoporotic patients, with 92% of them not receiving medication treatment. What the vertebral compression fracture registry showed, and this is the world's largest vertebral compression fracture registry, twice as large as the Swiss, and we had 1,094 patients in this. 10% of them had burst fractures, and the burst fractures of osteoporosis are different than those in the AO classification, as Dr. Schnake commented on peripherally just a few minutes ago. The burst fracture of osteoporosis is very much analogous to a champagne glass that would be dropped on a marble floor. The fracture fragments explode. And what we found is that if you treat these fractures, you have a very low adverse events rate. So out of 1,094 patients, the adverse events rate was 0.5%. And although the cement leak rate was 1 out of 4, there were not adverse events associated with the cement leak. The delta for pain improvement was 3 to 4-fold MSID, minimal clinically important difference, and the functional improvement was 2 to 3-fold. And this occurred no matter what kind of clinician was providing the treatment. So not only did the registry embrace the heterogeneity of disease, all fractures, all types, but it had a heterogeneity of authors and physicians who put in these cement augmentations. So it was put in by neurosurgeons, orthopedic surgeons, it was put in by PM&R, interventional radiology, pain, anesthesia. So there's a heterogeneity of real-world disease and a heterogeneity of clinicians treating, and all of them got remarkably good results. There's a second registry that was implemented for the sacral vertebra, and that also showed similar findings. So let's look at what the findings are. So these are findings on 732 patients. It's the largest registry in this. Patients with severely painful fractures that had disabling disability all had dramatic improvement that sustained over a 6-month period of time. So this is one of the most impressive outcomes for any orthopedic treatment. This is the slide that changed Medicare's national policy. And what they showed is this patient came into my practice 2 days after fracture. We took her to the ambulatory surgery center that day, performed the vertebral augmentation procedure. Her disability and pain scores dramatically changed and remained changed for 6 months after augmentation. This patient came into my practice 6 months after his fracture. Again, had sustained pain and disability, got dramatic 2-fold MSID improvement in the clinical condition, but did not get the results that the early treatment got. But the thing that Medicare focused on is this number. The cost tripled. The healthcare utilization costs of non-surgical care are 3 times the cost of acute care management, acute surgical care. And this is the healthcare utilization cost that Klaus Schnake was peripherally mentioning in the conversation earlier. This is the patient who was treated immediately. This is the patient who was treated at 6 months. And what you see is the primary cost of non-surgical care is in imaging. These are repeated MRI and CT scans. and return to the hospital or emergency room, either for admission or reevaluation. Those are the red bars. Appointments in physician office, those are the blue bars. So non-surgical management raises healthcare utilization costs because the patient's still painful and the patient comes back for reevaluation and reimaging. The important thing to realize is that we ran studies on these 21 patients randomly selected from one of our community hospitals that does this work. And we asked the question, after their cement augmentation, whether they were treated acutely, whether they were treated subacutely, or whether they were treated when the fracture is chronic. And we asked for all healthcare utilization costs referable to the fracture after the day of cement augmentation. And in all 21 of these patients, 100% of these patients, there were 0 healthcare utilization costs attributable to the fracture after their cement augmentation. Now, they may have come back for a cardiac event or a urinary tract infection or some other thing, because in this age group, they come back to the emergency room with some degree of frequency. But attributable to the index fracture, there were 0 costs. So what does the registry data show you? It shows you that cement augmentation of osteoporotic vertebral compression fractures is one of the more effective things we do. And that the registry data gives you real-world insights into what works and what doesn't work, independent of the type of physician that provides the care, independent of the type of fracture morphology that is being treated. The second thing that we concluded is first, do no harm. That's our oath. Non-surgical management does harm. Second, do good. If you treat these fractures, you dramatically improve the patient outcomes for function and pain, and you dramatically reduce the cost to society. And then lastly, basic orthopedic principles. If it's broken, fix it. And I want to give a special shout out to Paul Anderson and Mark Swinkowski on Own the Bone. What they're trying to do is convince our orthopedic colleagues that we should be taking responsibility for anti-osteoporosis treatment, because we see these patients. And their morbidity and mortality is directly related to how much we get involved. Our colleagues in endocrine and primary care have not succeeded. There's a 92% failure rate that I mentioned earlier. That's on their watch. And if we engage in taking care of the skeleton, this is one of the things that we can help people with. Thank you.
Awesome. So what's the cutoff at a spine fracture here? What's the cutoff again? I asked that question to Klaus Schnake,
yep.
and it's Schnake.
Yeah, you did. And he said 4 weeks.
He said 4 weeks. What is your cutoff?
So that was a 6-month outcome because I wanted to contrast that. And you also earlier saw some x-rays of, Kirk made a comment that he did a 4-level fusion on a patient who had a vertebral cleft. Vertebral clefts and osteoporosis respond beautifully to kyphoplasty. And Kirk made some comments about the fracture fragment splitting. So from the LCD's perspective, Medicare wants to see acuity. And the acuity is determined by the MRI. So the T2 stir, if it tells you it's an acute fracture, you should be treating it, because you will have a huge impact on the patient's pain and function. You may be treating a fracture in the subacute, just like if you had a broken wrist. If you're treating it at 2 to 3 months, you're not going to have the outcome if you're treating it at 2 to 3 days. Same with a broken hip, same with a broken ankle. So acuity is important. So we treat everybody as quickly as we can, but they don't get in to see us.
It's interesting, though. The MRI stays abnormal for about a year. So I know they want that for acuity. It doesn't tell you whether the fracture is 6 months old, 3 months old, or 2 weeks old. It just tells you it's not over a year old. But do you have a cutoff? At what point in time would you say it's ineffective? 3 months after a fracture, 6 months? At what point in time? Because the MRI will still be abnormal at 6 months.
Yep.
It takes a while for the marrow to revert to normal. At what point in time do you think it's ineffective? Because I don't think there's good data on that, really. At what point would you say, like, all right, it's too late to do this for you? I'm not likely to help you.
Okay, so I'm going to give you anecdotal. So first off, I showed parameters for time in going from 2 days to 6 months, and it's not my practice to be doing 6-month vertebral, but the patient's deltas were twofold, 2.5-fold MSID for pain and for function. So that's a win for the patient. Yeah. Our interventional radiology colleagues do this for chronic fractures that no longer have T2 stir. And I have a tough time getting my brain around it, but they in fact show data that it is beneficial. So for my own choices, absent data, I cut myself off at 3 to 4 months because I didn't mention this, but we were asked to build this registry by Medicare. The Medicare administrative contractor west of the Mississippi is called Noridian. Yeah. And the head of Noridian, medical director, came to us and asked us to build a registry because she sat on the board of SpineScope, the registry that Jens was referencing earlier. And she saw the dramatic data that we were able to deliver. And we showed her this data. All that data I showed her is her Noridian data. We showed it to all the Medicare administrative contractors, and that's what changed national policy because they saw it as their data. We limited it arbitrarily to the sensitivity of MRI. In our MRI reads, it starts to disappear at 4 to 6 months.
The stir or the T1? The
stir.
T1 for sure doesn't go away in 3 months.
Yeah,
but
stir.
Maybe a stir.
T2 stir. T2 stir is the acuity index that we use. And so for many of our reads, and so Medicare was supportive of the registry if it measured acuity. And so we used, and we didn't use bone scan, we used a T2 stir.
Is your cutoff 3 months then? Or
3 to 4 months is the cutoff.
So great stuff. And why don't we switch lectures? John, you're the hardest working faculty here. Give us a repartee. Are we overkilling? Neal did a very cool job. Thank you, Neal. Monumental work.
I missed the very beginning, but that was pretty compelling. The cost data was very compelling because I look at that, and because I'm very slow to do these. I don't do any acutely. I think most of them get better, but when I look at your cost data, that's pretty compelling because I can see that their cost is much higher. Right? That makes sense to me. Pretty good data. It's worthwhile stuff.
Yeah.
So I am very reluctant to operate on these initially, and I do my own, kyphoplasty, vertebroplasty. But it's interesting. The data is compelling, and that's probably I would have to say one of the better papers in the literature, or one of the better things that I've seen, because the issues of concern are pain, alignment, and I'm going to try to talk specifically about burst fractures, maybe a little bit because. Some of it is really no different than any other compression fracture. So it's an issue of pain. There is an issue of alignment, which is worse in burst. There's the issue of neurology and trying to avoid making things worse. So the literature, if you look up osteoporotic bursts, you will not find a single paper on non-operative treatment. Okay, it's all about whether you can do a cement augmentation in a burst fracture or will it go into the canal. And it appears that you can do that safely if you're careful. And I'd be interested to hear your take on that, Neal. But it looks like you can do that safely if you watch and are careful. And it's operative treatment in neurologically impaired burst fractures. So there is nothing on this. So I would say that if there's neurology, you're probably going to be forced into the surgical realm. That may or may not be true. I'll show you a paper that would refute that, but that tends to force me into an operative realm, and probably cement augmentation isn't doing it. So really we're talking about pain and alignment and trying not to make them worse. And I would say once you get to this point and neurology's gone, whether it's a burst fracture or a compression fracture makes no difference in the decision making. So what is the evidence based on osteoporotic fractures with neurology? This is 2 papers, which I found interesting. And in those 2 papers, the conclusion was there was no difference in neurological recovery and there were higher complications with surgical fixation, that the loss of correction was a big problem. And I will tell you, that's my experience. I don't know whether they recover less or not, but these are low energy fractures. It's not a high impact on the cord. These are kind of low energy squashes. And I tend to still address these surgically, but I will tell you there's data to suggest maybe it's not worthwhile. So, those are just examples of things that you can do. So what's the really the role? So if you look at this fracture, here's the problem when you start getting aggressive with these. And this is a patient that initially didn't have any neurology, but just had a lot of kyphosis. And somebody decided to do this. Well, short segment fixation can work in a young trauma fixation patient, but not an osteoporotic fracture. I'm not quite sure if they didn't recognize that this was an insufficiency fracture or just didn't understand. I'm not sure what it was because it did this. Okay, it didn't do anything. It just mashed through the screws. Whether they augmented that with cement, that would have protected the screws, maybe. That might be something I would do if I had to fix one, because it then turns into this. Okay, that's not what you want. So fixing osteoporotic fractures is a big problem. So even if you recognize it and say, I'm going to do things to try to mitigate this osteoporosis, I'll use multiple points of fixation, I'll cement screws, I'll cement augment up front. In these burst fractures, even if you recognize it, so here's a 57-year-old female. She was having some standard back pain. That's an MRI. 3 years later, she's now 60, and she has this burst fracture. You can see it's probably been there a little while. It's mashed down here. When she stands, it's very kyphotic, a lot of pain, some vague neurological complaints, and proximal muscle weakness. She gets a multi-level surgery trying to mitigate the osteoporosis, filling the pedicles with large screws, maximizing length of screws, and multiple points of fixation. What a good boy am I. 5 months later, significant increase in back pain. She now has an L4 compression fracture below it. Took 5 months, but she got it. Okay, so that gets cement augmentation. She actually did decent from that, okay? 8 months later, doing fairly well, some back pain at 10 months, sacral insufficiency fracture on the left. At 5 years, L5 compression fracture. It just keeps going. So we didn't stop anything. All it did was put stress up to her rate of caudal fractures. 7 years from the fracture, she's now only 68. She has diffuse back pain. She has postural issues due to the collapse at the lower lumbar spine. 10 years from the fracture, she's now 70. She's now kyphosing up over the top. She's more and more disabled. She's been on Forteo for 6 months, and she gets a massive procedure because she's still only 70. So would we have prevented that by doing nothing? Maybe a cement augmentation? Maybe. I think once you start instrumenting these patients, you're heading down a path. And it may not be your fault, but they're going to keep fracturing all around where you did it until you stop, she's not done yet. This is 18. She's not done. Like, we've got to get to her skull, then she'll be done. I'm embarrassed to say, we've been in practice long enough. Jens, how many occiput to the pelvises do you have?
I do.
Yeah, it is a little embarrassing when the fellows see them. I try to shoo them out of the clinic, before they can see them. But sometimes they catch me. So what about fractures with resultant deformity? So if we have a burst fracture, is it a problem to end up with deformity? Well, in general, these are very low demand patients, and mostly it's well tolerated. When they have, and I'm not sure simple augmentation addresses the deformity issue, and I'll show you some data. They can get pain over the apex, and maybe it's fracture, maybe it's pain over the apex. They also get ribs on the pelvis they complain about. So late pain from the deformity of osteoporotic burst fractures can be a problem. They also sometimes will get lumbar stenosis in response to the hyperlordosis. They aren't symptomatic. They have degenerative changes, asymptomatic stenosis. They kyphose over, so they lordose at the bottom. Now they're getting pain down their butt and the legs, not from the fracture, but from their stenosis below it. So it can be a problem for sure. The problem is the potential correction of a kyphotic deformity by re-expanding the vertebrae is pie in the sky, okay? There's also no correlation between that correction and pain relief. But if you try to look at this, so here's one of the papers showed that you got more rapid pain relief. And I don't think there's any doubt. When you do these early, they get pain relief. The problem is if you wait 6 weeks, it's about the same in most patients. And these studies aren't always good. I think there probably is a lot more money spent in that 6 weeks. So to me, that seemed the most compelling thing. But it's hard to demonstrate, beyond 6 to 12 weeks that there's benefits. Some papers do, some don't. So here are some of my thoughts. I mean, it is purely a pain control procedure. And if we can demonstrate, and maybe this study goes a long way, that the cost is less, that the patients mobilize more, their secondary medical problems are worse, their secondary utilization of imaging and therapy is worse, then I think it is worth trying to relieve their pain. To me, it can be hit or miss. I tell these patients, you may be dramatically better, you may be disappointed with what I did, you'll know within the day or two. It is not something you have to recover from, which is kind of nice. It does not correct deformity, and it doesn't prevent or minimize early deformity, as best I can tell. What we need is a prospective study where we have similar fractures and we can see whether the deformity progresses with or without. Does it prevent deformity? I don't know. It certainly doesn't correct it. And the natural history is that 78% do get better without treatment, okay? I tend to wait 6 weeks. And I tell them, if at 6 weeks you say to me, I'm in pretty good shape, I'm getting around, I'm doing fine, we don't do anything. If you feel like you're not progressing well, then we'll talk about cement augmentation. So for me, this 6 to 12 week time frame, maybe it's a compromise for what you showed, is what I use. But you have to mobilize the patient. If you don't mobilize the patient, then they get problems and they go to rehab and therapy. And so sometimes that requires encouragement. Sometimes I'm consulted because a patient's in bed 2 days in the hospital. I say, just get them up and walk them around and start them walking. And if they'll get up and mobilize, I wait 6 weeks. If they won't mobilize, that is the one group I do early. It's not an operation for young traumatic fractures. This has to stop. There is no reason to do this. And this is, radiologists can do this procedure, pain people. A lot of people are capable of doing the procedure. It's patient selection where the problem lies. And so I had a patient on a bicycle, a 30-year-old guy, had a mid-thoracic compression fracture. I saw him 2 weeks doing fine. He was getting close to a 6-week visit, got a call from the radiologist who finally looked at his film, told him he was in severe danger, had to come in immediately and get a kyphoplasty. He was already getting better. And his wife called me frantic. I said, do not go get a kyphoplasty. You don't need it. And so this is the problem, how they select patients. It's not whether they're capable. In fact, they have better equipment to do it, frankly. They have better imaging to do it. And so one of my partners utilized radiology to do the procedure, but she decided who would get it, and she followed them. So I think that's a decision we can make because they're very capable of doing it. It's just how they select them. It can be the problem. And so, this is just an example. Pre-op standing, you can see the kyphosis. When I put them on the table prone, the kyphosis corrects a little bit. I blow up the balloons. It looks pretty nice. I'm like, oh, this is nice. I take out the balloon and put the cement in. It settles back down a little. I stand them up, and it looks exactly like it did when I started. So does it correct deformity? No. Can it prevent progression of deformity? Again, maybe. If you look at studies, whether it's with a balloon or without a balloon, there's no improvement in kyphosis from one to the next. You probably get a little bit on the table, and if you can fill the cement up top to bottom, and I think one of the problems is you don't always fill the cement up. I think some of the pain relief honestly comes from burning the central vertebral nerve that people talk about for pain control. It may be a cautery issue. I don't know, because I'm not sure when I see like a thumbnail of cement in the middle of a vertebrae, why that would do them any good, but some of those patients are better. So what are we really trying to accomplish? If it's neurological improvement, I think we're forced down a surgical path. Maybe we don't have to. I don't know. Deformity requires a much more, if you're addressing their deformity, it requires a more extensive procedure, maybe supplemented. If it's pain control, remember that a lot of these patients do get better, and probably we need to mitigate the cost in there. I don't think any of them need repeat MRIs or CTs. So what I would say at this stage, for an osteoporotic burst, you do need a really good reason to treat it surgically. Maybe that's going to change.
Thank you, John. Yeah, we have, let's go to, can we switch? I can help you with that lecture.
Okay.
Klaus Schnake. So Germany has led the way with being more aggressive with MIS surgery for fractures clearly around the world. And you deserve singular credit for having advanced osteoporotic fracture assessments, gotten a classification through the German and now through the AO spine societies. And you've stratified treatment far more. So your response in terms of surgery, kind of John gave his negative view, and our partner and friend Neal Shonnard gave us a far more aggressive interventional perspective in terms of cementing. Be very curious to hear your global perspective, and thanks for hanging around.
Like 12 years ago, I took over the position as chair of the Osteoporotic Fracture Working Group in Germany, and ever since we have worked on classification, on scores, as well as treatment recommendations. And since we are treating these patients many times surgically, we have gone through a lot of, good and bad times. So just to show you where I am from, my center is located in Bavaria, in Erlangen, close to Nuremberg. Erlangen is a city where Siemens Healthineers is located, where the headquarters of Puma and Adidas are, so it's a relatively wealthy area. I have nothing to disclose. So you have to know that there's the osteoporotic fractures are somewhat different. They are different animals. So as I told you before, the majority of them are compression fractures, some burst fracture, but mostly not really highly unstable fractures. Logical deficits are rare, but they can occur, and then are mostly radiculopathies. And radiculopathies do not get better without surgical treatment. On the other hand, progressive kyphosis is common. This is very important, especially if the T-score is less than -3. And since we have different morphologies and with different courses in comparison to the healthy bone fractures, we have to treat them differently, and probably we need something like another classification, because otherwise, when we put them in the AO classification, we end up with all A1 as well as A3, A4. So in a combined effort, the AO Spine and the Osteoporotic Fracture Working Group developed the OF classification. It has only 5 subtypes. It's only relatively easy to memorize. Excuse me, there's something going automatically here, so I have to go back once in a while, excuse. So it's relatively easy to memorize, just 5 subgroups, and it's based on CT scan, MRI, and X-rays. So here are the 5 subgroups. We start with the OF1. This means no deformation visible typically on X-rays, but if you perform a stir sequence, you see a vertebral edema. If you have a deformation of one end plate with minor or without posterior wall involvement, then we talk about an OF2. If you have a deformation of one end plate with a distinct posterior involvement, that means like a classical incomplete burst type injury, then we have an OF3. Many of the fractures need surgery as the OF4, the deformation of both end plates, like complete burst type injuries, pincer type, or fish bones, once again. Or finally, injuries with anterior or mostly posterior tension band failures. These are the OF5. They typically do not occur immediately, but they, like insufficiency fractures, they occur over time. So how to treat? We've just heard about augmentation and maybe conservative. And of course, we can do posterior percutaneous. We will hear it in a second from John. However, conservative can be difficult. And John Franz said, yes, 70 to 80% can likely be treated conservatively, but there are some who fail. And if they have failed, then 6 weeks are probably too, already the collapse is too advanced. So it's better to estimate beforehand which patient will probably fail. And these are the one, as again, with a low T-score of less than -3 or less than 90 Hounsfield units, as well as the ones who have in fracture types like burst fractures and initial height loss within the first 2 weeks, showing intravertebral clefts are at the thoracolumbar junction, have or already a decompensated sagittal balance or develop because of the fracture, and some specific MRI types, like you've seen here, which have bulge either anterior or posteriorly anterior wall. So if you see something like this, plus a low T-score, then you should be cautious with your conservative treatment and follow up the patients quite nicely. Otherwise, it happens like this. Here's an 86-year-old woman. She had a fall 3 months ago. She was treated conservatively, and then she came back with this situation. She was 86. She was somewhat frail, but not too frail. But she was in really severe back pain, VAS of 8. She could not walk, freely. She could not stand upright. There was no logical deficit. We performed the CT scan and MRI, and you can see that in the CT scan, the posterior elements are elongated. So there's a PLC insufficiency, a cleft anteriorly. So I don't think that this is a good indication for kyphoplasty because it doesn't change the deformity. I totally agree with John. So kyphoplasty is a pain treatment, but not a deformity treatment. And here we need to treat the deformity because otherwise whatever you do will fail. So we performed an hypomocleon to see whether it opens up or not. But finally, we went for surgery. It's an O5, so a highly unstable situation. I performed a percutaneous stabilization from T10 to L2 and a thoracoscopic assisted minimal invasive corpectomy. And this is the intraoperative or just shortly postoperative results. It's very important to use these large end plates from the cage, and then, and then use the cement for the cage to settle on. If you don't have cement around the cage, then the cage will subside. So this is very effective treatment. This is only a 12-month follow-up, and you see we could nicely restore the age-adapted physiological alignment. And I think this is very important. If you fix them in a kyphosis, then they fail, and then they will have adjacent fractures. So once you start to put in screws and have a big surgery, you need to follow deformity rules. So that means you have to look for the global balance for the pelvic parameters and restore it nicely. And then the risk of failure gets relatively, I wouldn't say gets lowers. It's not that low, but it lowers at least. So there are a couple of things to think of when you consider surgery or not. So again, I think the first 4 weeks are very important because subsidence happens or kyphosing happens relatively fast. So things which are in favor for surgery are high pain, immobilization, the low T-score, neurological deficit, and ongoing kyphosin. For conservative treatment is, of course, if the patient is mobile, has moderate pain, is probably too frail, or has comorbidities. So we try to put this together in a score to have an aid for decision-making daily practice. So we said, okay, morphology, according to the UF classifications, the severity of osteoporosis plays a role, deformity progression, if you have images over time, the pain, whether it's high pain or low pain under adequate analgesia, whether the patients have neurological symptoms, how are they mobilized, and the health status. So we developed this point scheme and said, okay, we count everything together, and we have more than 6 points. Maybe surgery would be advisable. And this was our first attempt. And then we said, okay, this worked actually in our environment. And then we performed a multi-center prospective study where we included 580 patients. In 17 centers, 2/3 received surgical treatment, 1/3 conservative treatment, and the surgical patients had in general more severe fractures, so higher OF scores, as well as showed lower mobility and the day of decision, which reflects to the score. We had relatively low complications rate, 3% in the conservative group, 13% in the surgical group. There were no deaths and only 2 reoperations, but we had a couple of patients changing from conservative to surgery. All in patients improved clinically by following the treatment recommendations of the score, but we saw better mobility, a significant better mobility improvement in the surgical group. When we look at our data from my own center, we included 84 patients, 60 could be follow-up. We see the T-score was really low with -4. And the majority of patients were in the OF classification had OF4 type of fractures and had points more than 7. And of these patients who were treated, half of them surgically, half of them received kyphoplasty, 1/4 posterior instrumentation, mostly with cement augmented screws, and 1/4 received kyphoplasty posterior instrumentation, again, cement augmentation of the screw, which we call hybrid construct. So these were my group, or the groups of my patients. And what we can see here, that after an average of 32 weeks, the ODI as well as the VAS decreased significantly and gained the minimal clinical important difference. So the clinical outcome was relatively good in a very short time when we followed the score and performed in these patients operations or not. And what is most important, and really I think the most important thing, is that they regained the mobility level like they had before the fracture started. So all of the patients got back to the level of the mobility like before. And this, I think, is the most important thing, that we can regain, that patients regain their mobility, that we get them to a status like they've been before the fracture, because this has an impact on mortality on the long term. So by following the score recommendation, we could achieve this. So in general, we think that OF1, 2, 3, and sometimes even OF4 can be treated by kyphoplasty. So that's still the workhorse. We almost never do vertebroplasty. Kyphoplasty is reimbursed in Germany, and we think it's easier, less cement leakage, etc. These short percutaneous hybrid constructs, they are very helpful in OF3 and OF4 fractures. However, in some of the fractures, you need longer constructs, depending a little bit whether you have multiple fractures, etc. But as I told you before, we always try to do everything from the back and fix it percutaneously. That is, in the majority of cases, possible. Today, we only cement the uppermost and lowermost screws. We do not cement anymore the screws in between, because this is, from a biomechanical point, not necessary. In some cases, we need osteotomies and even anterior or posterior stabilizations, like in these cases. And then again, as I told you, you have to consider how long the construct is. You have to consider that you have to restore sagittal alignment. You have to consider that you may put cement in the adjacent vertebral bodies to avoid adjacent fractures. So the longer the construct gets, the more complications you will have and the more difficult it gets. So I would say, yes, when you start doing this, you will have a lot of problems, but after a while, you know where to look at. Just a case example here of a patient, 68-year-old, severe osteoporosis with a T-score of -3, fracture of T12. It was an OF3 fracture, so only the upper end plate was affected, although it looks a little bit on the upper right image that the lower end plate is affected too, but it wasn't. We performed the score just to show you how the score works. 6 points for the morphology because we doubled the classification. Then 1 point because of the low T-score. Kyphosis progression we did not know because we had no images over time. She was in pain, therefore another point. Had no allergical symptoms, no point, excuse me. Tried it conservatively, but patient did not get better. And then again, we used the score, and the patient had still 9 points, so surgical therapy. So the beauty of this score is that you can apply it every day. You see the development of the patient. If the score goes down, the patient gets better and you don't need surgery. If the score goes up or doesn't get better, then you perform surgery. And again, these hybrid constructs are our workhorses here. PMMA augmented percutaneous screws with the kyphoplasty of the index level. This works quite nicely in many cases. And it has been shown that this works even in not only in our hands. There are a couple of retrospective but already prospective studies showing that these hybrid constructs are effective. And what is most important, you see below, there's a study just recently published showing that they had less adjacent fractures, in comparison to cement augmentation or kyphoplasty alone. So again, kyphoplasty alone doesn't lead to necessary more adjacent fractures. But if you perform this short segment stabilization, you do not increase the number of adjacent fractures in comparison to kyphoplasty alone. So in conclusion, the classification and the score are, I would say, meaningful, and they're good clinical aids in the daily practice. They reflect the current knowledge of the treatment, and more data are coming up showing that this is probably a meaningful tool. Conservative therapy is definitely the first choice, especially if the patient is mobile and has low pain. Kyphoplasty and hybrid stabilizations are our surgical workhorses, and the longer you wait, the more aggressive you have to be, because when the conservative treatment fails. So again, we should avoid the failure of our conservative treated patients, and therefore either a score or at least these close follow-ups are quite important, because otherwise you need a lot of surgery to correct them, and you struggle with their comorbidities, with adjacent fractures and implant failures, etc. So the more surgery, the more complications. And again, like Neal Shonnard just said, adequate medication is crucial, because otherwise they all come back with no new fractures, so they need medical treatment. And with this, I thank you for your attention, and here's some take-home literature. Thank you very much, and I apologize for technical issues.
Klaus, excellent. Love the structure. John has an immediate repartee question.
Yeah, so this first question is for Neal and you, Klaus, and then I have a couple just for you. Do you have any sense, could you use this classification? Because I agree, once they get a deformity, it can be a bad problem. Some of them tolerate, some don't. Do you have a sense whether we can, with cement augmentation, we can prevent the deformity? I know we can't correct it. I mean, I'm pretty confident about that. Can we prevent it? Is there any data to suggest that we can prevent it, like maybe using a scoring system? Or Neal, what do you think?
Klaus, I don't use your scoring system. I use what Jim and John mentioned. I see these patients back a week later, and if their fracture has changed in any way, I immediately operate on them. If they have pain and dysfunction, disability, pain at 7 or greater, disability of 19 on Roland Morris, I immediately operate on them. And I never operate on a patient who has a neurologic deficit. That patient needs an open operation, not a percutaneous operation. So I do the operation that you indicate, where you do an open procedure, you augment the level, you reduce the neurologic deficit or whatever the fracture fragment is, and I cement a level above and a level below. But I only do open for neurologic deficit. Everything else is percutaneous cement augmentation.
So a lot of the collapse occurs pretty quickly, and the ones that are going to collapse. So if you see them at a week, it could get worse at 2. What percentage of the ones that you see collapsing at a week continue to collapse after cement? Do you have any idea? Is it a small percent? Or
it's an insignificant percent. I use the evidence of progression X-ray as a substitute for Hounsfield units. But if you have a CT, because most of the time I'm doing MRI, because I can do all of this work percutaneously, I don't expose the patient. But if they come in with a CT scan, and the Hounsfield units, I use double digits as an indicator. So if it's below 100, if it's double digits, 90, 87, anything that's double digits, I immediately move on, because that fracture is going to get worse right in front of my eyes. All I have to do is set the patient up for 3 weeks of sequential x-rays, and it's going to be quite obvious. So pain, disability, and osteoporosis risk, progression, or Hounsfield units are what I use to make the decision.
I think it's relatively similar to what we do and what we try to put in this score. I mean, if you would just for fun apply the score on your patients, you will probably end up with the same result and say, okay, surgery. So this score is an 8. I mean, you have your algorithm, and this obviously works, and I think it's relatively close to what we do. But our goal was to develop an algorithm which can help people who are not as experienced as you are, as John are, as me are. So who will say, okay, what can I do with this patient now? And we wanted them to look at, on pain, mobilization, on the severity of osteoporosis and so on, as well as on the patient condition to make a proper decision whether to operate or not. That was the goal. It was the score is not the goal. It has not the goal to be a help for you as an experienced surgeon, because you know what to do, but many others do not know. And with the regard to John's question, yes, kyphoplasty can restore a little bit of the deformity, local deformity. So and may help, to keep the normal posture. However, if the patient has already a disbalanced spine, it doesn't work. So I totally agree. It's useless if you have a deformity already. And then if you have a deformity, then the risk of further fractures is increased. So I would say, again, kyphoplasty is a perfect pain treatment. It works quite nicely, even after a couple of weeks, even after 6-8 weeks. But we have to be careful not to lose the patients who have a rapid kyphosing of their fractures, and these are typically the ones with a low T-score.
Klaus, and 2 more questions for you. What's the role of shortening? So when I'm fixing these deformities, I tend to not restore the height with an expandable cage, but to shorten and basically give them a flat vertebral plane that allows me to correct alignment. I feel like that puts less stress on my screws. What do you think the role of shortening is? And the other thing is if you're doing it percutaneously, at some point you're going to see lucency around this cement and screws. I mean, there has to be some loosening of the hardware. Have you had to revise any of these screws with the cement? It looks like those are fenestrated screws, I assume. Have you had to revise any of those? What happens with the cement?
So shortening is one option. I think that's if you have a severe kyphosis, shortening is a viable option. But what I do is I perform a CT scan and look at the bone, because sometimes you see then very sclerotic dead bone. And then I think shortening can be a problem, because if you cut through a dead bone, try to put it together, then it probably doesn't heal. So therefore, if you have these Anderson lesions where, sclerotic bones where there's no vital bone left, then I'm not sure whether this will heal, over time. So therefore, then I personally think anterior support is more meaningful. But in general, shortening is totally fine, to correct these deformities. The second question, loosening can happen, of course. It's more the cutout of the screws than the loosening. Mostly at the uppermost screws, they are the ones who typically cut out and cranially. Taking them out is not a problem, because the cement has no resistance to torque force, just to pull out force, but not to. So you can take them out easily, and you can even put in new screws through the cement. So then you just drill through the cement and put a new screw in. So we don't see any issues with that, So I think revision is not a problem.
Are they fenestrated screws, or are you just squirting the cement in and putting the screw in?
Yeah, so both techniques. We started with putting in cement and then the screws, but now we have the fenestrated screws, cost the same like the full screws, so solid screws. So we use fenestrated screws.
Does the screw break free from the cement then when you take it out? It doesn't try to come out as a clog. Absolutely, because the cement, again, there's no resistance to torque force. So you can just take the screw out. It just breaks. There's a small bridge, it breaks, and then it's easy to get them out.
Thank you all. Take-home messages from me are: there's better classifications, better risk scoring, a far more structured approach, and a far more kind of interventional, guided, thoughtful process where we as surgeons do and should probably take a much bigger role, and being the ones who also initiate the osteoporosis care and prevention. So these are take-home messages. We'll revisit those in our final concluding session. And Dr. France has been so kind to postpone his SI joint fixation, which is very important, to later. It's great to have you on board, Dr. Michael Fehlings. Thank you, Klaus. So one of the other